The first thing that we need to do is to introduce ourselves to the patient and create warmth and rapport. Pakcik, Assalamualaikum. Saya Dr. Latiff. Saya nak periksa Pakcik sedikit ya. Okay. The next thing that we need to do is to make sure that the patient is in good position. And for cardiovascular examination, we need to position the patient in 45 degrees propped up. And along with that, we need to expose the patient well. Pakcik, saya buka baju sikit ya. Adequate exposure of the chest is very important. Today we will demonstrate the techniques of examination of the cardiovascular system. Before we begin, after positioning the patient and with adequate exposure, the first thing to begin with is inspection. We start with general inspection, and we can look at the patient from the top. And what we do is to concentrate on what is on the patient and what is in the surrounding. We can look on whether the patient has got a venofix, on whether there is any drugs intravenously being infused. We can look on whether the patient is on an oxygen mask or nasal prong, or we can also look at his surrounding. Looking at the patient and concentrating on the inspection, we will look for evidence of central or peripheral cyanosis. We'll also see whether the patient has got deep breathing or tachypnea. And we also see whether the patient is comfortable or restless, on whether the patient has got cold sweats or any evidence of distress. After completing our general inspection, we will start the cardiovascular examination by concentrating on both hands. What we are looking for in both hands are stigmata of infective endocarditis. We will concentrate on the tip of the fingers first. We will look for evidence of clubbing at the nails and the nail bed, and after which we will look for evidences of splinter hemorrhages on both hands. Then we turn both hands and we concentrate also on the tip of the fingers to look for osseous nodes and Janeway lesions over the palms. After examination of the hands, we will now move on to examination of the peripheral pulses. We will start by examining the radial pulse. The radial pulse can easily be felt just lateral to the flexor tendons at the wrist. And there are two things that we need to examine while we are feeling for the radial pulse. The first thing we need to look for is the pulse rate. We can easily count the pulse rate and multiply the pulse rate by 4 if we examine for 15 seconds. The next thing to do is to concentrate on the rhythm of the pulse. What we need to concentrate on is whether the pulse is regular or irregular. Most often, the pulse will be both irregular in volume as well as rhythm. After concentrating on the radial pulse, we then move on to brachial pulse. There are also two things we need to concentrate on the brachial pulse. The first thing is the character of the pulse. And the second thing is the volume of the pulse. The brachial pulse is central, therefore representing the exact volume of the cardiac output. After completion of examination of the brachial pulse, we would then do the collapsing pulse. It is very important to have a good command of a proper technique of examination of the collapsing pulse. For a patient's right hand, we will start by using our left hand. What we do is to concentrate and grip on the wrist firmly until we are able to feel for the radial pulse at the tip of our palms. Then we slowly release our grip until the pulse disappears. As soon as it disappears, we tell the patient that we are going to lift his hands up. Pakcik, I'm going to lift your hands up, yeah? If there is presence of collapsing pulse, we will start to be able to feel for it again. If it is absent, then it will be absent both in this position and in that position. We now proceed to the examination of the face. We will concentrate on the eyes and look for areas of xanthelasma, which is an important sign of hypercholesterolemia. Then we examine the eyelids to look for evidence of anemia. We now ask the patient to show us his tongue. Can you show me your tongue? And we will now concentrate on examination of cyanosis, which will appear very clearly around the mucosal membrane as well as the tongue. Okay. Next, we will examine the jugular venous pulse. The first thing that we need to look for is the position of the jugular venous pulse. What we are interested is in the internal jugular vein, which actually starts between the two heads of the sternocleidomastoid. This is the area that we start looking for pulsation, and it will go towards the pinna of the ear and the angle of the jaw. Throughout this line, we should look for pulsation which comes as a double pulsation. Among the character of the jugular venous pressure or the jugular venous pulse is there is a double pulsation or dual waveform. After concentrating on this line, we should check whether the pulsation is actually the JVP and not the carotid pulsation. We can do this by attempting to feel for it. One character of the JVP is it is visible, but it is not palpable. The next thing to do is to attempt to occlude it. If the pulsation is easily occludable, and if we can see that the pulsation, the vein starts filling from the top, then it gives us more confidence that it is the JVP. The final test to do is to look for the hepatojugular reflux. We can do this simply by compressing the upper part of the abdomen. And by doing this, we can see that the JVP or the pulsation will increase for a short duration. And this is called the hepato or the abdominojugular reflux. After examination of the jugular venous pressure, we will now concentrate on the precordium. Pakcik, I will expose your chest first. The first part of the examination is inspection of the precordium. What are we looking for? We're looking for evidence of median sternotomy scars or any other scars over the area of the precordium or the chest wall. We will also look for evidence of any changes in the feature of the chest wall itself. There are two well-described abnormalities of the chest. One is called pectum carinatum, where the center part of the chest is prominent, looks like a bird's chest. The other one is pectum excavatum, where you can see that the chest, the center of the chest is depressed. These are abnormalities seen most often in children. We now concentrate on the apex, and we look for any evidence of pulsation over the fifth intercostal space, mid-clavicular line, or its surrounding. We also then look for other areas of pulsation, if any. After completing our inspection, we will now concentrate on palpation. It's important that our hands are warm before we start touching the patient. Pakcik, saya nak rasa ya. The first thing we examine on palpation is the apex beat. The apex beat is defined as the lowermost and outermost prominent pulsation. We will concentrate to locate where it is. After finding where it is, we will now identify the exact point of the apex beat. We can start by feeling for the second intercostal space, which is just below the sternal notch, sternal angle, and count 2, 3, 4, 5, and that is the fifth intercostal space. And now examine for mid-clavicular line. This is the normal area of the apex. There are two things we need to comment about the apex beat. One is its position. Two is the character of the apex beat, whether it is forceful or normal. After concentrating on the apex beat, we now move to the left parasternal area, of which we look for evidence of left parasternal heave. We can use the tip of our palms to examine for any heaving, which is a reflection of right ventricular hypertrophy. We then go from apex, which is the mitral area, tricuspid area, which is the lower left sternal edge, and the pulmonary area, which is at the second intercostal space left to the sternum, as well as the aortic area. In these four major areas, what we are looking for are thrills. Thrills are actually palpable murmurs. The next sequence of our examination is auscultation of the precordium. Before we use our stethoscope, we must make sure that the position of the stethoscope is well defined. One is the diaphragm, the next is the bell. Diaphragms are for high-pitched sounds and the bell is for low-pitched sounds. The first area for auscultation is the apex, and it is important for us to position our diaphragm at the area where we felt the apex beat. We will now concentrate on the presence of first heart sound, second heart sound, and if there is any third or fourth heart sounds. We then move our stethoscope to the lower left sternal edge, which is the tricuspid area, concentrating on whether there is presence of any added sounds. We then move to the pulmonary area, which is the second intercostal space just left to the sternum. It is very important for us to concentrate on the second heart sound here in the pulmonary area. In patients with pulmonary hypertension, the second heart sound will be loud. The next area to auscultate is the aortic area. And we are now looking for any added sounds. We then turn our stethoscope from the diaphragm to the bell to listen for low-pitched sounds. We go back to the area of the apex. We will now concentrate on whether there is presence of a mid-diastolic murmur, which is usually difficult to hear unless we use our bell. Then we stand back and concentrate on which area did we hear an abnormal sound. After concentrating on this area, we will now go for a second listen and concentrate on where we heard the abnormal sound again. If there is presence of a cardiac murmur, we should always look for radiation. For example, a mitral regurgitation murmur will radiate to the axilla, and we will follow it to look for its radiation. Another example is an aortic stenosis murmur, which is an ejection systolic murmur, best heard over the aortic area. It will radiate to the neck. And we should continue listening to the neck. In certain position, an aortic regurgitation murmur, for example, is best heard with the patient sitting forwards and in deep expiration. So it is important before we complete our examination or auscultation of the precordium to ask the patient to be in that position. Pakcik, can we sit forwards? Right. So concentrate on the lower aspect of the left sternal edge using the diaphragm. With the diaphragm in position, we will give instructions to the patient. Please take a deep breath in, breathe out, and stop there. Okay. Thank you. Breathe normally. Right. An early diastolic murmur of aortic regurgitation will be exaggerated in this position as well as when the patient is in deep expiration. For every murmur that we hear, we need to be able to describe 5 things. One is the timing of the murmur. Is it in systolic or a diastolic murmur? The second thing is the duration of the murmur. Is it a pan or an ejection, an early or a mid diastolic murmur? The third aspect is the grade of the murmur. The most commonly used grading of murmur is grading 1 to 6. The fourth description of the murmur is where is the area best heard. Where is the murmur best heard over the 4 areas that we have auscultated. And the final 5th description is whether the murmur radiates to any other position. While the patient is in this position, we will take advantage of this position by then concentrating on auscultation of the respiratory system. We will use our diaphragm and concentrate on the bases of the lungs, and by asking the patient to breathe deeply in and out. Please breathe deep and out, in and out. What we are listening for is for basal crepitations, and basal crepitations are signs of cardiac failure. For completeness sake, examination of the abdomen is considered to be part of cardiovascular examination. Patients who have chronic heart failure can present with hepatomegaly, and patients with infective endocarditis can sometimes present with splenomegaly with or without hepatomegaly. Examination of the liver is gently done by compressing the lower aspect of the abdomen and slowly moving upwards towards the right hypochondrium. While palpating gently, we will instruct the patient to breathe in and out slowly. Breathe in and out, Pakcik. If hepatomegaly is present, the tip of the liver will be felt touching our fingers. Examination of the spleen should start from the right iliac fossa, and gentle palpation should proceed towards the left hypochondrium. Again, similarly, ask the patient to take deep breaths in and out. The tip of the spleen will be felt touching on the fingers while we are palpating the spleen. Examination of gravity-dependent edema is a very important part of cardiovascular examination. Gravity-dependent edema will be present over the lower extremities if the patient is mobile, or it can be present at the sacrum if the patient has been lying flat for some time. The way to examine both lower limbs is to concentrate on a constant pressure for a constant duration of time. We first concentrate on the lower 1/3 of the legs, and the area to apply pressure is over the shins. I would suggest that we apply a constant pressure of around 2 seconds. And while doing this, it is important for us to look at the face of the patient as not to cause discomfort to the patient. As soon as we lift our fingers, what we are looking for is indentation over the skin. If it is present over the lower third of the legs, we can now proceed to the middle third of the legs and then proceed on to the upper third of the legs. If the edema is more severe than this, it will cause scrotal edema, and worse than that, it can cause ascites. Examination of the cardiovascular system, we will have an idea on what abnormalities the patient would have. We will be able to describe the pulse of the patient, the blood pressure, the jugular venous pulse, and evidences of heart failure. We will also be able to detect murmurs if present, which will indicate the presence of a valvular heart disease or congenital heart disease. We should conclude our examination by arriving with a clinical diagnosis. It is important to have a purpose of examination and a conclusion at the end of the examination. A clinical diagnosis is very critical in achieving a complete examination.